I started the record.
Yeah. So, good evening, all. I welcome you all for this month's nursing training program. So, we all know that how blood component therapy is important for our day-to-day practice in pediatric hematology and oncology and bone marrow transplant services. So, this month we are going to discuss that. For this, we have with us Dr. Ravindra Prasad. He's consultant and head transfusion medicine and stem cell apheresis at Apollo Cancer Center, Chennai. Along with him, we have Dr. Usha. She's junior consultant transfusion medicine at Apollo Cancer Center, Chennai. So they'll be discussing with us regarding blood component therapy. And meanwhile, I'll request all the participants to put any questions in the chat box so that after the discussion, we can discuss those questions. So over to you, Dr. Ravindra.
Yeah, good evening, Dr. Shivani and the team. Thank you for having us online today on behalf of IAPPHO chapter. So I am joined by my colleague, Dr. Usha, who will be delivering this topic. We all know that blood transfusion is indispensable for blood disorders. Let it be a malignant disorder or a non-malignant disorder, blood transfusion is almost certain. More so in the BMT setting. So almost any individual, let it be an adult or a child, is going to need blood in the pre-transplant or around the transplant, peri-transplant setting. So as a healthcare workers, it is very important for all healthcare personnel who are concerned in transfusion to know about the good transfusion practices and blood components. More so for doctors and nurses who are directly involved in blood transfusion. So realizing or stressing upon this need, this IAPPHO chapter has called for a training on blood component therapy in BMT setting for nurses. So I believe over the next 30 to 40 minutes, so where Dr. Usha will be discussing about various aspects of blood components and transfusion practices. So I think it will benefit all nurses who have joined here today. So thank you. Over to you, Dr. Usha. You can start.
Thank you, sir. So let me start my presentation today. So about blood transfusion in pediatric hemato-oncology patients. So they need blood because the disease itself will cause a requirement, or it could be a therapy-related requirement. So blood transfusion is a critical life-saving part of care in these children. And if you see the pediatric patients who are receiving transfusions, more than half of the transfusions go to this patient population. So the transfusion is not just one time, it is multiple times, and it could also be long-term. So let me introduce you to blood components. So we have packed red blood cells, fresh frozen plasma, cryoprecipitate, platelets, and granulocytes. So the packed red blood cells can be stored for 42 days. The fresh frozen plasma can be stored for 1 year. Same for cryoprecipitate. And for platelets, it is only 5 days. And for granulocytes, it is not a stored component. You have to transfuse as soon as it is collected, preferably within 6 hours. And you should transfuse within a maximum of 24 hours. So what I want to highlight here is that these have terminal, the shelf life is limited, so you cannot store it for long in the blood center. So how do these components help patients? So what is the rationale, or what is the purpose of transfusion? So we use red blood cells to increase the oxygen carrying capacity, and this happens in acute or chronic anemia. So for plasma, it is to restore the multiple coagulation factors, wherein you have multiple coagulation factor deficiency. It could be surgical blood loss, it could be liver issues. And for cryoprecipitate, it is rich in factor 1, factor 5, factor 8, factor 9, and von Willebrand factor. So when these factors are deficient, specific factor concentrates are procured from pharmacies, or if they're not available, cryoprecipitate becomes a choice of component. And for platelets, you can see in many hypoproliferative conditions, bone marrow failure syndromes, or any hematologic malignancies like leukemia or post-BMT, you need platelets. And granulocytes, any leukocyte, congenital leukocyte issues, like CGD, or you require granulocytes in post BMT patients, or neonates with alloimmune thrombocytopenia, it may be indicated. So these are the purposes of transfusion. So what are my unique challenges in pediatric patients in the context of transfusion? So pediatrics, we know they are of small size, so they are easily prone for fluid overload. And when I transfuse blood after blood, the stored PRBCs may release potassium. So in the supernatant, there could be potassium levels which can be harmful for the recipient child. And even the additive solution which contains mannitol is of concern to neonatal population. So the next point is they are developmentally immature. So the example for this is even for blood grouping, in the reverse grouping, you cannot expect ABO antibodies. So for neonates, you have to go by forward grouping. And the immunological immaturity is reflected in the fact that neonates and fetuses, they are prone for transfusion-associated graft versus host disease. And another thing is, since their hepatic and kidney status are immature, they may not metabolize citrate as good as adults. So when I transfuse blood after blood, the citrate toxicity is to be considered. So another thing about kids is that they go through multiple stages. So they evolve from being a fetus and then to a young infant, from to the newborn period up to 4 months of age, and the physiology is a bit different after 4 months of age, and then they grow up to 18 years. So during this period, what happens is that their weight keeps changing, and they have age appropriate hemoglobin levels which need to be kept in mind, and their total blood volume keeps changing. Those need to be considered at the time of transfusion. And another thing when we talk about pediatric is that they have a long life ahead. So whatever you do now, it should not affect them later in life. So should we consider anti-D prophylaxis when Rh negative children are receiving Rh positive? That is important. And some guidelines say that you have to give KEL negative packed red blood cells in female children, because later in life, if they conceive, and then that should not cause hemolytic disease of fetus and newborn. So a lot of considerations because of this particular feature. Another thing is some children around 16 years of age may get admitted to adult wards. So the adult transfusion practices may be applied to these children. So that should be kept in mind. And another most important thing is that when the guidelines are framed, we need a lot of evidence, and this evidence is still lacking for pediatric, specifically to pediatric hemato-oncology. So whatever is being practiced for adults, some of the guidelines are adapted for children, for pediatric population also. So there is requirement for more evidence. So now when we go to packed red blood cells, we know that chronic or acute anemia, you need to transfuse, but what exactly, or when you should transfuse, or when you should stop transfusion? So the general guideline is that when you have a stable child who is non-cyanotic and not bleeding, you can wait up to 7 grams per deciliter. Or if the child is unstable or having symptomatic anemia, you have to consider a higher threshold. So for cases who are going for surgery, in stable patients, 7 is the transfusion threshold. And for pediatric hemato-oncology and HSCT patients, a threshold of 7 to 8 grams per deciliter is being practiced. So for hemoglobinopathy on chronic transfusion programs like sickle cell and thalassemia, maintain between 8 to 10 grams per deciliter. And for sickle, you need to maintain the sickle percentage to less than 30% for good survival. And in chronic anemia, other than hemoglobinopathy, the threshold is given as 8 grams per deciliter, like, for example, Diamond-Blackfan syndrome. So another thing about hemato-oncology is some of the patients can undergo a process called red cell exchange. For example, sickle cell patients will need a red cell exchange in the case of cerebrovascular accident, priapism, or acute chest syndrome. So that is one of the new indications. And another thing is we use a lot of machines as part of treatment. So likewise, for this red cell exchange or ECMO, you have a circuit, and you need to prime the circuit, because the extracorporeal volume, when you connect the patients to this machines, too much of blood is outside the body, and if it exceeds more than 15% total blood volume of the child, it will ask you to prime the circuit with PRBC. So these are all the indications. Like I mentioned, when you talk about transfusion less than 4 months of age, you have a separate guideline. So this is just to make you familiar with the American guidelines. So for less than 4 months, as you can see, if the neonate is on ECMO, you have a higher transfusion threshold, or depending on the oxygen requirement, you can go it is given as hematocrit less than 30%, or a child neonate having less than 20% hematocrit with low reticulocyte count and with symptoms, you need to transfuse. So coming to the next component therapy, when do you need platelets? So there's a lot to discuss in this table actually. So a stable child and with hyperproliferative marrow, you can wait up to 10,000 per microliter for platelet count. And when it goes less than 10, whether there is bleeding or not, you have to transfuse. That is the guideline. And when you have a higher platelet count, but there are other factors which are making the patient sick, for example, sepsis, or the patient is on anticoagulant, or there are some invasive procedures like the child needs a lumbar puncture or a CVC, you need to go for a higher hemoglobin threshold of 20,000 per microliter. And if you see there is major bleeding, it is a higher threshold of 75,000 to 1 lakh per microliter. So another thing to be seen here is when you have immune thrombocytopenias, platelet transfusion is actually contraindicated. So only if there is life-threatening bleed, they transfuse platelets. So another situation is where you have neonates with consumptive thrombocytopenia, and the transfusion threshold described here is 25,000 per microliter. So what is important is that you should not go only by the count. You need to see the other patient factors and the clinical setting to decide your transfusion. So that is why the practices may vary between institutions, although they may be following the guidelines, and it is the clinician can decide to transfuse as per the requirement. Coming to fresh frozen plasma, what is to be highlighted is it should not be based on, the transfusion should not be given purely on laboratory tests. So there should be signs of bleeding along with settings of coagulopathy, or the patient may, in the same setting, they may have a planned invasive procedure. Another thing is acute disseminated intravascular coagulation. It is not only the laboratory parameters like more than 1.5 times prolongation of PT, APTT, or fibrinogen less than 1 gram per liter. It is also the rate, how rapidly the fibrinogen is falling down, and the severity of bleeding that should guide the therapy with FFP. And another indication is warfarin reversal. And like I said, specific factor deficiencies, if you don't have concentrates with you, you can go for FFP transfusion. And like I mentioned, for red cells, there is also something called plasma exchange, and plasma is required as a replacement when you do the exchange. FFP can be misused very easily, and it should not be used just to improve the blood pressure of somebody, or like a source of proteins, or just to correct some mild abnormalities in the laboratory values, or there is no there is bleeding but the coagulation tests are normal, so the bleeding could be due to something else and not because of the coagulation factors. So in these situations, you're not supposed to transfuse FFP. Same for cryoprecipitate, you have the indication as active bleeding and fibrinogen level of less than 1.5 gram per liter. And for surgical cases, if there is a low fibrinogen level of less than 1 gram per liter, and the child is at risk of significant bleeding or to critical sites like neurosurgery or in the eyes, so you need to consider a transfusion. And for acute disseminated intravascular coagulation, usually initially FFP is ordered, and if the fibrinogen doesn't improve with FFP, you can go for cryoprecipitate, or if the fibrinogen level is too low, like less than 0.5 gram per liter, you can consider cryoprecipitate directly. And again, the rate of fall of the fibrinogen level and the severity of bleeding is important. So where cryoprecipitate is not indicated is, like I said, just to correct some mildly decreased fibrinogen values where there is no bleeding, even before surgery, or liver diseases with no active bleeding or minor coagulation abnormalities. Now, coming to the next component, granulocytes. It is a type of white blood cells, and it is usually given when there is severe neutropenia, like absolute granulocyte count of less than 500 cells per microliter. So this happens in congenital or acquired bone marrow failure, or they are on intense treatment for some hematological malignancy, and the bone marrow is affected and they're not able to produce the neutrophils, and proven or highly probable case of fungal or bacterial infection which is not responding to antimicrobials, and and also in situations where neutrophil therapy is likely to get recovered, neutrophil count is likely to get recovered, and future definitive therapy is planned. So regardless of neutrophil counts, if the child has congenital disorders in neutrophil function, along with infection which is not responding to antimicrobial therapy, you need to consider granulocyte transfusion. So whatever I mentioned is therapeutic indication. So prophylactically is granulocyte indicated. There is no evidence for benefit. Sometimes secondary prophylaxis, like the infection has already set in, but there is a later plan for myelosuppressive treatment and which can cause subsequent severe neutropenia, granulocytes can be given. And when you stop the granulocytes, there is clear evidence of bone marrow recovery in the form of increase in neutrophil count to more than 500 per cubic millimeter. And there is resolution of infection and clinical, there is no resolution of infection and clinical deterioration despite 3 transfusions, or the patient is reacting severely to granulocyte transfusions. So in these cases, you should stop the granulocytes. Like I told you, where granulocytes are not indicated, so there is no active treatment planned, and there is a bone marrow failure, and neutrophil is expected to recover on its own. So another thing is pyrexia of unknown origin or sepsis in the absence of neutropenia, or viral infection in the absence of proven infections. So these are all situations where you should not give the granulocytes. So what we saw till now is that when to transfuse so that it is appropriate. Now you should know how much to transfuse. So when you come to red blood cells, it is usually 10 to 15 ml per kg, and you can expect an increment of 2 to 3 gram per deciliter. At this point, I would like to say that when children have less body weight, like less than 20 kg child, you have to calculate the volume and decide in ml exactly how much you want to transfuse. So there is a formula which I have displayed here. And coming to plasma transfusion, it is again given as 10 to 15 ml per kg, and the expected increment is 15 to 20% rise in factor levels. And for platelets, you have to give for every 10 kg, you can consider 1 RDP, or you can remember as 5 to 10 ml per kg, which will give a 50,000 per microliter rise in platelet count. And for cryoprecipitate, for every 10 kg, you can give 1 to 2 units, which will give a 60 to 100 milligram per deciliter rise in fibrinogen, assuming 100% recovery. Now, what about granulocytes? So granulocytes, the volume could be 10 to 15 ml per kg, and it is mainly the cellular dose. So for young neonates, you can go for 1 to 2 into 10 power 9 cells. And for older children, you can go for 1 into 10 power 10, which is the dose in adults. Now, how do you select the blood group of the donor unit? It is very easy. Whatever the blood group of the patient is, you need to ask the same group. But what happens is, due to inventory situations, you may not have whatever you request for. So you have the alternate choices. For example, you have an A positive child, you can go for an alternate as either O positive or A negative or O negative. So likewise, for the various blood groups, I have displayed here the alternate choices. Now, there is one situation called hematopoietic stem cell transplant. The thing is, they decide the donors based on HLA matching and various other factors. But what happens is that the donor will be of some other blood group and the recipient will be of some other blood group. This does not stop a transplant, and this should not stop a transplant. But however, as transfusion services, we should be ready to support this patient. Now, what is of problem here is, when both have different blood groups, you need to know is that there are 3 phases. So one is phase 1, where the blood composition of the recipient will be fully of recipient origin. And this phase is right from the time a patient is identified as a candidate for transplant until the conditioning or the infusion. And then just at the time of conditioning until engraftment is the phase 2, where in the blood of the patient, you will see the blood composition consists of both the donor origin and the patient origin, recipient origin. And in the phase 3 post engraftment, you can see that the blood is composed of cells fully of stem cell donor origin. So this should be kept in mind when you select blood components. So there is a chart here which is displayed. The first 5 situations is called major ABO incompatible transplant. The last 2 is bidirectional. So let me take this example. Here the donor is, the stem cell recipient is O, and the stem cell donor is A. So the recipient has anti-A and anti-B antibody, and here the stem cell donor, the incoming graft, is A. So this is a situation of major incompatibility. So these situations here which I have displayed, they're all minor incompatibility. So the thing is, they will go ahead with the transplant, but you need to decide what products need to be given. So in the phase 1, what is recommended is you go for RBCs of recipient origin, and for platelets, it will be of the donor, whatever the donor group, that will be the, for phase 1, both the components, the the PRBC and the plasma components should be of recipient blood groups. And in the phase 2 is when it gets a bit confusing. So you need to use the for example, in the first situation that I mentioned, you have to go for OPRBC and the platelets should be A, or the alternate choice would be AB for platelets. So likewise, you have various combinations which are mentioned here. And after engraftment, when the recipient converts fully to the donor blood group, you can select the donor PRBCs. So what is important here is, in our center, we have a blood request form which is dedicated for BMT recipients. That is, we can mention what the stem cell recipient's blood group is and what the stem cell donor's blood group is, so that the transfusion services can guide in selecting the blood components. So your job is to coordinate with the blood center as to decide which is the best component at that point. So whichever phase the patient belongs to, you need to coordinate with the blood center as to understand which blood component is, which group of the blood component is required for these patients. This is a slide that I would like everybody to be familiar with. So you can make special requests to the blood bank. So there is something called aliquoting. So what is it? So you can give a smaller volume of any component. So why do you need it? Because you have younger children who are very of less weight. So if you ask the blood bank, they'll give you a smaller volume of the component. Like for example, if you have a PRBC, typically it is 250 ml. So if you ask for an aliquot, you may get in 100 ml aliquots. So the next thing is, for pediatrics, we can ask for volume depleted component, which means, for example, in platelets, you need 1 unit of STP for a bigger child, but somehow the patient has edema and volume overload is already present and you don't want to give more fluids, but you need to give platelets. You can ask the blood bank to give you a reduced volume depleted component. So I can give you the same component in a reduced volume. So this reduces the risk of overload in such patients. So there is a concept of fresh unit. So what is it? It is just blood from a recently donated unit. So this is usually indicated like in intrauterine transfusions or neonatal exchange transfusions, where up to 5 days old blood can be used. Another indication is the hemoglobinopathies, like for example, in sickle cell disease, they need a they may usually require a 10-day-old blood, or if they are going for red cell exchange, you need to use a 1-week-old blood, that is recommended. And in thalassemia, up to 14 days. So 14 days old blood, up to that point in time, they may accept the unit. So another thing is leukoreduction. So what is it? You're going to remove the leukocytes in the component. So it is applicable for red blood cells and platelets. What are the clinical indications? So you have multiply transfused people who are prone for febrile non-hemolytic transfusion reactions, or you have immunosuppressed patients who are you need CMV negative, cytomegalovirus negative components for these immunosuppressed patients. Or another thing is, you have a candidate who may go for future BMT. So you don't want the risk of HLA alloimmunization or HLA alloantibodies to form. So you may request a leukoreduced blood component right from the pre-transplant stage itself. So this is the requirement for leukoreduction. Then there's one more special request that you can make is the irradiated component. What is it? You're exposing the blood unit like PRBCs and platelets and even granulocytes to gamma or X-rays. So, so what does it do? It will inactivate the lymphocytes present in the blood which you are planning to transfuse, and because these lymphocytes can cause transfusion associated graft versus host disease, which has a 90% mortality in immunocompromised patients. So what are the clinical indications? Again, intrauterine transfusions and neonatal exchange transfusions, and any immunosuppressed child, and BMT patients, and also in people who have good immunity, but they are receiving the blood from close family members like a directed donation. So these are the situations you have to consider irradiated units. So another thing that you can request from the blood bank is red cell antigen negative unit. What is it? You want a red blood cell, but you don't want it to have a particular antigen expressed. So why this is important? Because some patients, because of repeated transfusion, they may produce a red cell alloantibody. And when you transfuse a unit, you need to make sure that the transfused unit does not carry this antigen, so that they will survive well inside the body of the recipient. So that is very important. Another thing is, you can just ask for red cell profiling or antigen matching. So what is this? You are going to transfuse a PRBC, which will have the same antigens as that of the patient. So for example, in a hemoglobinopathy like sickle cell or thalassemia, you know that they're going to receive blood lifelong. And once they start the transfusion, it's not going to stop till they have the curative treatment plan. So their blood will be mixed with donor cells, donor transfused cells. You don't know what their actual phenotype is. So prior to the first transfusion itself, it is recommended to see their phenotype and know what are the cells what are the antigens they're already expressing, so that in future during immunohematology workup or when you want to avoid a certain antigen, you know what it is. So another concept of red cell antigen matching is used in autoimmune hemolytic anemia, where the patient produces antibody against his or her own RBCs. So in this situation, the cross matching, it becomes difficult, and there is interference because of the antibody in the cross match. So you can go for a best matched unit. That matching is primarily for the red cell matching. So another situation is daratumumab, where you use this medicine interferes with cross matching again. So in patients who are using this daratumumab, before starting daratumumab, please order a red cell matching so that it will help in obtaining compatible units and matched units later. So what are the antigens to which you are going to match? So based on clinical significance and based on different studies, what they say is that, for example, you have sickle cell, you need to match for RH antigens, KEL antigens, KID antigens, Duffy antigens, and capital S and small s antigens, because these patients are more likely to produce antibodies in this blood group systems. So that is what is usually practiced clinically. So then you have the HLA matching and HPA matching. This is primarily applicable to platelet products, because some patients have HLA aluminization or HPA aluminization, which is human platelet antigen, and they go for factoriness. So even if you match with for ABO blood group for the platelet, it will not suit the patient. The platelet count will not increase. So you have to go for HLA matched or HPA matched platelets. Another manipulation is saline washing of the blood components, where you wash the components with 0.9% normal saline. This is to primarily remove the plasma, which is the plasma proteins are the major cause for causing severe allergic transfusion reactions. So when you want to avoid severe allergy or anaphylaxis reactions, or even HFN-HTR, a trial of saline washed components can be given. Or sometimes when you have a neonatal or fetal transfusion, you need to select a unit which was very recently irradiated, like literally less than 24 hours irradiated blood. But if you don't have it in your inventory, but that is the only unit available to give to this neonate or fetus, you can consider saline washing to remove the plasma which contains the potassium, which is harmful for the which is likely to cause problems for the recipient. Now, then there's something called platelet additive solution. So it is just an additive solution for platelets. In fact, in foreign countries, they're trying to see whether we can store platelets for more than 5 days. So in India, that practice is not allowed, but we are allowed to use platelet additive solution wherever we want to avoid exposure of the patient to the donor plasma. So we can use this platelet additive solution to issue platelets across the ABO group. So whenever you have less number of donors supporting your blood center, but you want to give platelets and you did not get a donor in the suitable blood group, you can issue across the group by using platelet additive solution in the product. So then you have pooling of components. This is nothing but just bringing all the contents into one final bag. This can be given for pooled Buffy code, pooled cryoprecipitate, pooled random donor platelets for the ease of transfusion. And sometimes when you want to leukofilter RDPs, instead of filtering one unit after another, you just pool everything together and then do one step of leukofiltration, so that becomes easier. So then there is something called cryopoor plasma. So while preparing cryoprecipitate from plasma, the supernatant is obtained, that is called cryopoor plasma. It is sometimes indicated in, it is usually indicated in thrombotic thrombocytopenic purpura, where you want to avoid exposure to von Willebrand factor to the recipient. So another that you can think that you can do is donor exclusion, like you can avoid female donor derived plasma. So this strategy can be followed to prevent recurrence of or incidence of TRALI in your setup. So another thing is reconstituted blood. So you can, now you know that whole blood is no longer issued as whole blood, it is always separated into components. But there are situations where you have to reconstitute PRBC and plasma together to create something like a whole blood, and this is usually given in exchange transfusion for neonates. Then there is something called directed donation that can be requested from the blood center. For example, in neonatal alloimmune thrombocytopenia, where the maternal platelets may be the only suitable platelets for the child having low platelets less than 25,000, or when you have platelet refractoriness and when we want to go for HLA matched donations, which I just mentioned. Another thing is IgA deficient component. So when you have a patient with IgA deficiency and producing anti-IgA, these patients may be prone for anaphylactic reactions when they are exposed to donor plasma which contains IgA. So you can request these components to make blood more and more safe for your patients. So now this is something general. So how do you organize a blood transfusion? It starts from the bedside. So you have to consider few challenges in pediatrics. So right from the consent. So being a pediatric patient, you know that it is a consent should be taken from the parents or the legal guardian. Another thing is the patient identity should be adequate care should be given to establish the patient identity. You should use positive patient identification on both occasions when you're drawing sample for ordering blood or when you're just before transfusion. The children may have a tendency to lose their wristbands or remove it. So you need to exercise due caution at this stage. And another thing is venous access. So in pediatric hemato-oncology patients, you know that they are easily thrombosed. So you might have to need a central venous access. So that may be of concern. Another thing is sampling. So for pediatrics, you have dedicated microtubes for collecting small volume samples. And sometimes you need to pair it with maternal sample. For example, in neonates who are having HDFN, or even for a transfusion for a neonate, you always request a maternal sample up to 4 months of age of the child. And the frequency of sampling should be considered. So there's something called iatrogenic anemia. Every time you remove a sample from a child or from anybody, there's a loss of 0.007 gram per deciliter fall in hemoglobin. So this is tolerated by adults, but it may not be tolerated by neonates. So this is very important. If you can reduce the frequency of sampling, another method is your blood bank can offer a type and screen policy where repeated cross matches can be avoided, especially for younger children up to 4 months of age. So this strategy can be followed. And for you have to go for pre-medication or advice. You should ask your doctor what pre-medication should be given. If it is a volume sensitive patient, should we go for a diuretic? Or if it's a patient prone for repeated severe allergies, should I give anti-allergic? So this consideration has to be given. Another thing is scheduling the timing of granulocyte transfusion. So you have patients on antibiotics and antifungal. So one of the antifungal is amphotericin B, and when amphotericin B and granulocytes are concurrently administered, a dangerous pulmonary reaction can happen. So you should always schedule the timing of the transfusion. You should space it at least by 4 hours, sometimes up to 6 to 8 hours. So you can avoid such reactions. Another consideration is the anti-D prophylaxis, which I mentioned already, when you're going to give across the RH group for an RH negative in a recipient. And like I told you, for hemoglobinopathies, you're going to go for lifelong transfusion, and you should be considering vaccination against hepatitis B prior to their first transfusion. So what is important in the request form is the blood group itself. So has the blood group been determined already? Was there a problem in the blood group? That has to be mentioned. And the history is important with respect to previous transfusion, transfusion reaction, transplantation, and in the case of neonates, previous obstetric history. Everything becomes important for this population. And what special, so I mentioned a lot of special requests that you can make to the blood bank. So what is it that you want for your patient? That has to be mentioned in the request form. And these are the do's and don'ts for bedside practices. Simply put, you should always label the sample in the sample circle. The sample circle is the immediate area around the patient, and you need to label immediately after collection, and you should not assign the work to anyone else. So that is very important, apart from the positive patient identification. And please inform the blood center in advance. See, for a simple plasma and cryoprecipitate transfusion, there is a thawing step involved where we melt the frozen components. So that may take around 30 to 40 minutes. So you need to plan. Another thing is PRBCs, pediatric left and right, you're going to ask for aliquots. So we need to transfer the bag from the component from one bag to another. So we need to aliquot it. So that may need time. And saline washing, if you want to prevent allergic reactions, that may take time. And once we saline wash, it has to be used within 24 hours. So we will wait for you to tell us if we can do the saline washing, because are you going to use it within 24 hours? We need the confirmation. So for platelets, pooling is routinely done, and pooling and leukoreduction and pass preparation. So for everything, time is needed. And specific mention for FSS granulocyte collection, it is actually a 2-day process. You cannot ask the blood, it's not, I mean, you cannot expect the blood bank to have stored FSS granulocytes or any granulocytes because they are not stocked products. So you need to identify a donor, test him, mobilize him, and then collect the next day. So it's a 2-day process. Coming to administration of blood, you know that just before transfusion, you're going to do a lot of pre-transfusion verification. So that is very important. So what is of importance here is, since we are going to have a lot of special processing requested for pediatric hemato-oncology patients, always check the bag label. When you have requested for leuko-reduced component, does the bag mention that it has less than 5 into 10 power 6 leukocytes? And if you have asked for saline washed components, have they mentioned that it has been washed? If you have asked for irradiated components, have they mentioned the method of irradiation and when it was irradiated? And most importantly, once you irradiate a PRBC component, the shelf life is no longer 42 days. It reduces. So once you irradiate a component, it is only 28 days from the date of irradiation or the original date of expiry, whichever is earlier. So accordingly, you need to check the bag label and the compatibility report and before proceeding with the transfusion. So another important thing is, please start the transfusion within 30 minutes of receiving the blood unit. So special consideration for pediatric would be, you need infusion pumps and syringe drivers to deliver specific rates of transfusion. So whatever you use, you still need to use a standard blood filter of 170 to 200 micron. So another thing is, when you have massive hemorrhage, when you want to rapidly transfuse, you can use external pressure devices, but the pressure should not exceed 300 millimeter mercury. And some situations warrant the use of blood warmers, but you cannot use just any warmer. You should use a dedicated warmer which is specifically meant for blood and which is maintained well. And this situation happens in exchange transfusion and IUT, and even for younger children, when you go for exchange transfusion, you can consider. And patients with clinically significant cold antibodies, or when you are rapidly transfusing like more than 15 ml per kg per hour. So these are the situations where blood warmer is required. So now coming to the duration of or the rate of transfusion. So PRBCs, usually it's 5 ml per kg per hour. You start very slow in the first 15 minutes of transfusion, and you can go up to 150 ml per hour. And usually the transfusion gets over within 2.5 to 3 hours, and at no point it should exceed 4 hours. So for fresh flows in plasma, you can start at 2 to 5 ml per minute, and then usually it gets over within 1 to 2 hours. And for cryoprecipitate, as rapidly as tolerated. And for platelets also, it is as rapidly as tolerated, usually 2 to 5 ml per minute. And always in fluid overload patients, please go slow. And in granulocytes, you can go for 1 to 2 ml per minute. Usually in this situation also, it should not exceed 4 hours. So coming to the transfusion reactions, I would like to just mention one line for every reaction. So in transfusion reactions, you have two types, classified as two, acute and delayed. Acute is within 24 hours and delayed is after 24 hours. Even after 30 days of transfusion, a patient can have a delayed reaction. So when you see the acute here, because of transfusion errors, like for example, a patient has received the wrong blood, that can lead to severe acute hemolysis. This febrile non-hemolytic reaction, you can reduce the risk by using leuko-reduced components. And allergic reaction, like I mentioned, you can pre-medicate or use saline washing. And same goes for anaphylaxis. And anaphylaxis medical emergency. You need to transfuse in the ICU setup and go very slow if you want to prevent the recurrence of such reactions. And transfusion-related acute lung injury, it can happen within 6 hours of transfusion. And be careful during your granulocyte transfusions. And other hemolysis due to other causes. So when you handle a blood wrongly, when you expose it to excess heat or excess cold or excess pressure, the red blood cells in the bag will simply lyse, and that will lead to problems that should be taken care of. In transfusion associated cardiac overload, be safe with in prescribing for volume sensitive patients. And there are younger children are more prone for hypotensive reactions, so that needs to be kept in mind. And sepsis, if the bag is contaminated for some reason, that can lead to sepsis reactions in an acute manner. And most importantly, when you're dealing with young kids, they may not come out with classical symptoms. It's just the irritability, agitation, or inconsolability that should alert you towards a transfusion reaction. And coming to delayed reactions, as you can see here, it's delayed serological transfusion reaction. It is nothing but alloimmunization. For example, you have repeatedly transfused people like sickle cell disease and thalassemia. So they may start producing blood and red cell antibodies against minor blood group antigens like anti-KEL, anti-Duffy, anti-D. So this is called delayed serological transfusion reaction if it is not associated with hemolysis. If it is associated with hemolysis, it is called a delayed hemolytic transfusion reaction. A special mention for sickle cell disease children here, they are prone for hyperhemolysis in a delayed manner. So what happens is, whether there's an antibody or not, they can have somehow they end up destroying their own red cells. You need to take care of, you need to closely monitor a sickle cell disease patient. So they are prone for delayed reactions also. And this is post-transfusion purpura. It can happen after 5 days of transfusion, and there's a sudden profound thrombocytopenia, and there's a high mortality rate. You need to pick this up. And transfusion-associated graft versus host disease, I mentioned the various indications for irradiated blood. By any chance, inadvertently, a non-irradiated blood is given to an immunosuppressed patient or an immunocompetent patient who's receiving a close family member's donation, this can set in. So that has to be avoided. And regarding transfusion-related iron overload, for example, thalassemia, you know pre-transfusion hemoglobin has to be at a certain level, and you keep transfusing every 2 to 5 weeks. But what happens? Iron slowly starts accumulating in the heart, liver, and endocrine organs. So you need to start the chelation therapy to prevent this, to at least minimize this iron overload. And transfusion transmitted infections, this is always a risk for any patient population. So what is the outcome of any blood component therapy? So it is the improvement of blood parameters and the reduction of symptoms. And for pediatric patients who are on long-term transfusions, it is also the growth and development of the child. So that decides how good the transfusion therapy program has been. So I would like to conclude by saying that blood components are essential part of care for pediatric hemato-oncology and BMT patients, and strong evidence is still lacking for pediatrics, especially in this blood oncology and HSCT patients. And the general thing is to go for restrictive transfusion. They want to minimize the volume of transfusion and not transfuse repeatedly. Only when the threshold is reached, they want to transfuse. And apart from the type, timing, and dosing of components, you have to decide when the special processing is needed, because that is very critical for safe transfusions. So these are my references, and I'm now ready to take any questions.
Thank you very much, Dr. Usha. I must say that, and I think everyone will agree to it, that it was an excellent talk, and you covered it very well. So I think the important message here for everyone is to have a dialogue or communication with your blood center. So whenever you are ordering a blood transfusion, it is always good to have, communication with your blood bank person about what is the patient status, what product do you want, or how urgent or how planned it is. And it will always help us to plan or prepare the patient in a better way. So we have a couple of questions in the chat box. First is, what are the most common mistakes nurses make during pediatric blood transfusion and how they can be prevented? I think Dr. Usha partly covered it in her slides when she was showing the bedside practices, but Dr. Usha, if you have any further comment on it.
So it is just, I would like to mention about the HSCT recipients. So once they are engrafted, within few weeks of the transplant, they get discharged, and then they come as outpatients for follow-up, or they may need transfusions for some reasons. So please mention the stem cell donors blood group and the original patient's blood group, so that we will recognize that this is a post-BMT patient. So that is very important. And in my clinical experience, as soon as a transfusion is ordered, please take the consent and plan the IV line and everything, because once you order a blood component, you cannot return it. I mean, you should minimize the returns. So we don't want to face return of blood components, and because we issued it only because you asked it. So we don't want to expose the blood components to inappropriate temperatures. So please take the components only when they are actually ready to be used. So I think.
So next question is, how important is caregiver education regarding blood transfusion in pediatric cancer treatment.
So the thing is, blood transfusion is the therapy. It's such an integral part that you cannot skip not talking about. You cannot skip talking about blood transfusion when you're planning therapy. So you have to integrate it as part of your routine counseling, and you need to have you. Maybe you can refer the patient to the blood center as soon as the treating doctors and the nurses who are handling these patients. You can refer these patients to the blood bank as soon as you know that the patient will require not only today, for the coming days. What is your plan? So you can coordinate with the blood center and inform the patient family as to what is to be expected. And especially in BMT, it is a predictable thing. So they need platelets from the 5th day till about 15th day. It's not new. Every BMT, whether it's adult or pediatric, they are going to need this platelet support. So you need to sensitize the family that this is not only for their patients, because I have really encountered situations where family thinks that it is only for their patient, for their BMT, the child is requiring the platelets. So you need to know that it's a predictable demand in situations like BMT. So family counseling is very, very integral, and you need to, in fact, in NABH, it is insisted that family counseling for blood donation and arrangement of donors be part of your counseling. And in fact, in our center, we have integrated with the consent form of transfusion itself.
Yes, I think it is very, very important to make them aware that blood is going to come only from the donation. So that is one part for arranging blood. And also we should equally emphasize on when we are taking the consent about the possible reactions, about the possible side effects which can happen, but emphasizing equally at that time that it is even important to give the therapy. You cannot not give blood or platelet transfusion. That's equally important. And what she mentioned, it is very, very important for bone marrow transplant patient, because when they are in the unit, it is kind of safe, secure environment. All the nurses know the protocol. That time there's only BMT staff handling those patients, so we know that this is patient's blood group, this is donor's blood group, and what component to be given. But as soon as they are engrafted or they are discharged, then the game changes, because they come in most of the institute, they'll come to daycare or some other area. So at that time, when the blood demand form goes, that time it should be clearly mentioned or communicated to the blood bank as to what day post transplant that patient is. Has he changed the blood group or not? What was the donors and what was the patient's blood group? So another question is, I think Dr. Ravindra Prasad has already answered that can infusion pumps cause hemolysis during blood transfusion? So yes, it can cause in some amount. And next question is, can we give PRBC platelet granulocyte infusion together, or there is any time frame needed? I think what she meant is whether any gap is needed between the transfusions.
I mean, anyway, clinically, you cannot volume overload the patient. So anyway, you're going to go one component after the other. So usually if there is bleeding, the platelets are taken first, and then followed by the PRBCs. And for granulocytes, most importantly, it is with the amphotericin, the scheduling. So you need to make sure. Sometimes granulocytes can give a good increment in hemoglobin itself and platelet count, because the granulocyte product itself, it contains hemoglobin and platelets. So maybe you may not need platelets and hemoglobin for that day. So that may also.
Yes. So can we transfuse in central line if antibiotics and chemo is on flow?
See, very important question. Whenever you transfuse blood, it needs a dedicated venous access. You cannot mix it with any other, even any other IV fluid or any antibiotic. So whichever venous access is dedicated for the transfusion, you have to go with it.
So I think it is very important, and throughout the lecture, she has emphasized more on that even blood transfusion therapy or blood component therapy should be considered as a drug or pharmacotherapy. So when you are giving, what you are giving and how you are giving is clear, and that should be always kept in mind. And like any drug can have side effect, even you can have transfusion related problems as well. So Dr. Dharni is here. She's also joined, I think, now. So thank you very much, Dr. Usha and Dr. Ravindra. It was an excellent session, and I'm sure our great nurses have learned a great deal regarding the blood component therapy.
I would like to ask if Dr. Ravindra has any closing comments.
Yeah, thank you, Dr. Shivani. I think Usha has made it very clear and regarding the blood components and the right way to transfuse. One thing nurses should understand is like blood component is from donors only. So they have to take some responsibility in motivating the family or making them at least understand that. So blood centers can support blood when only when somebody donates that. And also they should one problem here is what nurses commonly do is like get the blood in the right time. They should get the blood in the right time and complete transfusion in the right time. So within 4 hours, they should complete that unit, means within 4 hours, it should get completed and order the blood only when it is required, when you're ready for transfusion. Other than that, I think with repeated education, most of the practices are getting right nowadays. So that's why even the hemovigilance data, if you go through, the data is improving. The practices are improving throughout the country. We are not seeing such sentinel events with blood now.
So
Thank you, Dr. Shivani.
Thank you so much, Dr. Ravindra. If you will be kind enough, we have 2 more minutes and there are 2 questions, quick questions in the chat box.
Yeah, sure.
What are the problem arise when we transfuse blood in chemoport line?
See, as such, we should not mix blood with any other thing, right? So no drug and blood should be mixed. We don't know which drug can cause lysis, which drug can cause clumping of blood cells. We don't know. So it is not advised to mix blood with any drug or any fluid except normal saline. That too, we don't advise you to take the decision, nurses to take the decision of mixing blood and normal saline also. Suppose if you are using the same like a central line for infusion, make sure that you have flushed the line adequately with normal saline before use. But never use a chemoport. I think it is very dedicated for chemotherapy only. You should not use it for blood because you know now when there is a clump in the chemoport, so the cost and the effort goes behind maintaining and inserting that chemoport. Everything goes waste.
So I think by and large we can use for chemoport line, but we just have to be very careful in small babies where the chemoport French are very small or pick lines in the neonate where we use very tiny Frenches. At that point of time, only the blood transfusion or Paxil transfusion is not recommended because of the lysis. Other than that, if it's an adult French or a bigger gauze, we can, I think, transfuse.
I would like to mention about the blood transfusion set as it is, because the guidelines say that you should not use it between components. The blood transfusion set has to be used only for one component, and even if it's one component, it is allowed only for 4 transfusions or within up to 12 hours, not more than 12 hours. So you need to change the BT set when you're actually changing between components. So maybe that is also relevant to this question a little bit.
I think next is like a clinical question with peripheral blood stem cell and bone marrow transplant. Difference is like peripheral blood we take from the peripheral veins after mobilization. So bone marrow collection is done in OT from the bone. So in just a nutshell, that is the difference. But after transplant, I think it is like both are same except for the difference in engraftment periods.
Yes. So thank you so much. Thank you, Dr. Ravindra and Dr. Usha. I'll hand over to Himanshi for the closing remarks. Thank you.
Thank you. Thank you, Dr.
Thank you so much for joining me. I'll end the session now. Thank you.